You are live, sir. Please start. You are live, sir. Please start, sir.
Okay, should I start?
Yes, sir. You are live. Please start.
Just a minute. Good evening, friends. It's such a pleasure to have you all again in the wonderful Friday evening, in the 13th webinar of the series of our unique clinical pulse Delhi CSI initiative, the PG Track program. And we have a wonderful topic for you today evening. That's intravascular imaging basics and beyond. And we have Dr. Ankush and Dr. Arun Mohanty as our panelists. And one of the phenomenal speakers, Dr. Ajit Mullasari, the director of the cardiology department from Madras Medical Mission, who's one of the stalwarts and pioneers in intravascular imaging, who is here with us on this journey. So over to you, Dr. Mohanty and Dr. Ankush, to introduce Dr. Mullasari, and we start with the segment. Thank you so much.
Welcome, welcome, Dr. Ajit. Let me introduce Dr. Ajit. Thank you, Delhi CSI, for organizing such a wonderful topic. Unfortunately, in India, the penetration of intra-coronary imaging during training program, particularly during our DNB or DM training program, is very little. Most of the government hospitals and medical colleges are lacking these facilities, and whatever we have now, most of the private institutions are doing much more imaging work. So it should penetrate to the training program. It should be a part and curriculum of training, DM and DNB training. We have Dr. Ajit Mullasari, who is one of the most one of the pioneer in imaging work in the country, and he has multiple publications, and he's doing lot more researches in intracoronary imaging and putting it into data and publications in reputed journals. Now also he's conducting 3 or 4 international trials, and we are planning with his leadership one important trial in India also, erosion trial, which is OCT based acute coronary syndrome trial. And let us hear from Dr. Mullasari what he says and what he has for these residents particularly. Thank you, Dr. Mullasari. You can.
So let me just get my screen on and just one minute. Okay, so basically we are talking about intravascular ultrasound and OCT. Basic science interpretation and case examples, and in the next 45 minutes, I will go through what we need to know about intravascular imaging. So when you look at intravascular imaging, it is like looking inside the coronary arteries like an endoscope, and we have various ways of imaging which can help us, and these can help us to see inside the vessels. Now, if you look at intravascular ultrasound, you have a mechanical transducer, you have a driving shaft, you have a rotating element, and there's another one which is the phased array transducers, which ultimately have multiple elements to have a look at inside the coronaries. While in OCT, there are 2 types, which are the time domain OCT and the frequency domain OCT. The difference is, in time domain, there is a single frequency laser and the mirror keeps moving. While in the frequency domain, the laser is sweeping while the mirror is fixed. But basically, the acquisition is done by the catheter, which is placed inside the coronary artery, and the fiber optic cord then pulls back into the vessel segment. And during the image, the blood clearing is required so that you get a good image of the OCT. So these are the basic things that we need to know. In OCT, there's a time domain and a frequency domain, and there's a catheter which goes across the lesion. And to clear the flow, you need to have a clearance of the blood easily, and the catheter pulls back and takes the pictures. Between intravascular ultrasound and OCT, the difference is the actual resolution. Now, intravascular ultrasound is getting better and better. We are getting now 60 megahertz, and what will happen ultimately will be close to OCT. The actual resolution of an OCT is much, much higher. So you can see nearer images much better. The pullback is faster, and the tissue penetration is lower than the intravascular ultrasound. So between an intravascular ultrasound and an OCT, if you need to choose, if I want to check the plaque characteristic, an OCT is very good for the lipid and fibrous part. But for calcium, both intravascular ultrasound and OCT are good. OCT is very good for near calcium, and IVUS is good for adventitial calcium. For knowing plaque vulnerability, OCT is good, but IVUS also with virtual histology can be used. For involving the plaque burden and the remodeling index, IVUS is better. So it depends on what you want to do. The interesting thing is that the OCT is very good for follow-up of patients, especially for post-PCI stent evaluation. For the stent, it's a great tool. IVUS requires a lot of experience to read. An OCT, once it is taken up properly, you can have a good picture. You can make a decision very, very quickly. Most people can make their diagnosis much more simpler with an OCT. To know the physics of ultrasound and IVUS, you have light, and both light is used for OCT and IVUS uses ultrasound. They hit from the catheter through the lumen on the vessel wall. There's a first tissue interface where there's a reflection, after which the light refracts or the sound refracts, hits the second level of the tissue interface, and the light or ultrasound gets thrown back at the catheter, which is called as reflection. These images are then collected by the respective ultrasound and light catheters, and decisions are made. So you have 3 levels of interface, and according to that level of interface where the light or ultrasound reflects, you get various images of ultrasound and OCT. Now, we have to understand these have time delays, intensity changes, and reflective delays. So these make ultimately the picture that you ultimately see. So when you have an ultrasound and OCT, you should remember that you need to have the 3 basic physics part: the shadowing, the absorption, and the attenuation. And all this ultimately leads to the picture that you see. Now, the intravascular images which you see are analogous to histological sections. They are oriented from the ostium of the coronary artery. In the IVUS or OCT, there is no absolute anterior versus posterior. And there's left versus right orientation of the images. The side branches will help you to diagnose, which is an diagonal or an LAD or an obtuse marginal or an acute marginal branch to what is the direction of the picture. We also could use perivascular landmarks like pericardium, muscle, and venous system to orient the image. So the image is exactly like a histological section. So you can see on the left what an IVUS looks like, and you can see how the histology looks like, and you can see the intima, the media, and the adventitia very, very nicely, just like the histology. And the pictures that you take is like as if you're looking into the coronary artery, and the picture interpretation is like a clock. So we say, okay, there's a 10 o'clock problem, there's a 2 o'clock problem, or there's a 6 o'clock problem. And this is how you describe an intravascular ultrasound or an OCT picture. Now, for a normal coronary artery, you can see the middle part is the intravascular ultrasound, and the outer part is the OCT. And you can see the difference of picture. In the OCT, you can clearly make out which is the intima, which is the media, and which is the adventitia. In the IVUS, it sort of gets a little bit fudgy, but good IVUS pictures can show it. The catheter is right here in the OCT. Here it's in the IVUS, it's right here. And this is how the pictures look like. The cartoon is on the right. So that's the lumen. That's the intima. You can see it on the IVUS and the OCT. That is the media. In the media, you can see it beautifully in the OCT, the darkest shadow between the two bright shadows, and then you have the adventitia. So this is how you make the differentiation of media, adventitia, and intima of the coronaries. So you saw a normal coronary, and if you have a diseased coronary, what you see is that there is some sort of thickness of stuff which is below the intima or below the intimal space, and this can fuse the whole area between the intima and the two elastic membranes to form the diseased area. So this is a typical fibrofatty plaque which is seen in a patient in the coronary artery, and this is how it looks on an IVUS, and this is how it looks on an OCT. And you can look now, the lumen is here, the intima is here, the media is here, and the adventitia is outside. So when you in an IVUS characterize, you have one issue which is echogenicity, which is comparing that to the echogenicity of the adventitia. In the IVUS, the adventitia is very bright. The shadowing, which is a complete reflection of the light rays from the surface. Attenuation, which is a reduction in the intensity of the lights as they pass through tissue due to absorption or scattering. And reverberation, which is multiple reflection artifacts from highly reflective surfaces. So you should know these four terms when you're looking at IVUS. One is echogenicity, the shadowing, the attenuation, and the reverberation. When you look at IVUS, there are some simple images which you can see. So as I told you, this is the catheter, this is the lumen, this is the intima, and you can see that there is stuff here, which is basically the fibrous plaque. Here you can see calcium in the intima, very, very bright echoic spots. Here is a plaque which is very soft, and you can see the plaque very, very clearly. And here is a highly attenuated, that means it's absorbed a lot of stuff, and it's characteristics of a very lipid-rich plaque. Again, you can have an echo-lucent plaque here, which you can see here is where the intima is, and you can see again, this is a very, very fatty plaque. It's like a pre-ruptured plaque. It's a very, very vulnerable plaque. And you can have a mixed plaque, which basically has components of calcium, components of soft tissue, which is fibrous and fatty. And then you have a plaque rupture with a cavity. And then you can have a floating stuff inside the coronaries, which is the thrombus. So all these can be seen on the intravascular ultrasound. So you can see fibrous plaque, you can see calcium, you can see a soft plaque, you can see an attenuated vulnerable plaque with high fat, which is very, very clear here. Now, this is how the plaque looks like on histopathology, very, very, very attenuated. You can see echolucent plaques like this, which is seen here. This is the histology. You can see a mixed plaque. You can see a plaque rupture with a cavity, which is clearly seen there. And you can see the thrombus moving in and out when the picture is being taken. Now, this is an angiogram of a person who had a previous MI and came to the hospital with some chest discomfort. And during the angiogram, you can all see that there are sort of small shells in the coronaries seen. And this in post-ACS scenario is suggestive of two things. It could be either on an angiogram, a spontaneous coronary artery dissection, or it could be a recanalized thrombus. And IVUS and OCT both can show beautifully what it is differential. But here you can see multiple holes in the whole thing, and this is typically like a recanalized thrombus with multiple cavities inside. So it's like, this is the plot, and you can see like multiple holes inside, and this is a typically recanalized thrombus on an IVUS. An OCT would show it much better. Now, the another thing which you should always be careful when you're doing stenting is that you should see what is the intramyocardial course. And here you can see this is the intramyocardial course of the LAD, and that's important because that's usually a muscle bridge on the LAD. And it's important here because you should not put stents into intramyocardial bridges because they will get broken, the stent will get broken. So you can use an IVUS to exactly show the muscle part of the intramyocardial bridge, and then we can put a stent in if required. Here's a patient who had a stent very precisely placed just before the myocardial bridge, so that we can very be clear that the bridge is there, you can see the bridge nicely squeezing the coronary and the stent starts there. So we can make decisions about stenting outside the bridge. So here's an angiogram which shows an aneurysm, and again on iris you can see the pocket of the aneurysm very clearly. A huge aneurysm which you can see in this picture on the intravascular ultrasound. Now the coronaries can remodel either positively or negatively. A positive means that the artery is bigger, while negative remodeling means the EM to EM ratio becomes smaller. So it becomes, this is very important, diabetic patients negatively remodel, and the danger here is if you try to oversize a stent, you will rupture. The importance is to measure the internal EM to EM exactly so that you don't oversize your stent. And it's important that your proximal and distal lumens may be bigger, and your distal and proximal EMs may be bigger, and you don't use the same parameters which you normally use for imaging in these vessels. It can be the other way around also. The EM to EMs may be larger, in which case you can afford to go up on the vessels. And this is how it looks like in the coronaries. You can see negatively remodeled vessels and positively remodeled vessels very nicely. So we have some ratios. I won't go into that right now. Now, when you go to OCT, you again need to know a few things. The characterization of OCT is by backscatter, which is basically the reflection of light waves off the tissue and back to the catheter, which is shown as bright. Attenuation, which is reduction in intensity of the light waves as it passes through the tissue due to absorption, which is basically seen as dull. Shadowing, which is a complete reflection of the light rays from the surface. The composition can be homogeneous, means it is similar, the whole composition of the whole plaque. Heterogeneous, which is dissimilar. The texture can be coarse or fine. The edges or borders can be sharp or diffuse. So when you describe a lesion with OCT, you have to put all these issues in when you describe it. So as you can see in the OCT, the pictures are much easier to interpret and much easier to know than in an intravascular ultrasound. For example, a fibrous plaque, all of us can see. From the intima, you can see the plaque, which is a golden colored reflective plaque, which is seen here. There's a fibrous plaque. And you can see when the plaque becomes sort of attenuated or blackish, you can see it's a high lipid containing plaque. These are the plaques which will cause distal embolization when you put a stent, and you have to be very careful with this. And then you can have a very sharp demarcated area which is attenuated but with sharp border. This is calcium. So this is different from this. This does not have a sharp border. Here you can see very sharp borders, and this is calcium inside the coronaries. So you can make out what is calcium and what is lipid and what is fibrous plaque very simply by looking at the OCT. So that's a fibrous plaque. It's homogeneous. It's got a high backscatter. It's got a low attenuation. The lipid plaque, which basically is homogeneous again, it has got low backscatter, but it's high attenuation and a diffuse border. And you have a calcific plaque, which is heterogeneous. It's not similar looking. It's got low backscatter, low attenuation, but it's got a very sharp border. So these are the ways that you'll identify the various types of plaques. You can also see the intraluminal abnormality. So you can see here there's stuff inside the coronary, which is clearly attenuated and is floating in. This is red thrombus in a plaque erosion. White thrombus is again free floating, but it is non-attenuated and it is bright and floating in. These are platelet ones, and this is usually thrombin. And I showed you the recanalized thrombus on an iris. In an OCT, a blind person can see this is like a lotus stem. These are the clots which have opened up, and lumens are here. This is all the clot stuff which is organized. And this is a subacute coronary artery dissection, spontaneous coronary artery dissection, which is basically the lumen gives way to an intrahumeral hematoma and the artery dissects inside the coronaries. So that's your thrombus, red, high Bax factor, high attenuation, white thrombus, high Bax factor, low attenuation, recanalized thrombus, mass with channels, intact media, and SCAD, where you can see the blood in the media going through. Now, plaques can heal spontaneously. And again, we have to see, if you have plaques which have healed, what you see is signal-rich layers of different optical density located close to the intraluminal surface with clear demarcation from underlying tissue. Histology is like this, and here you can see multiple types of tissue, which have clearly, it's like a healed possible rupture which spontaneously healed in a patient. Now, when you identify plaque vulnerability, that is the ability of the plaque or the reason for the plaque to give away to form a thrombus in a plaque rupture and creating an ACS, there are certain characteristics of that. One is you should have a thin fibrous cap. So this is the lumen, here's the lumen, and you can see a thin cap. This is called as TCFA. Thin cap fibroatherioma. So this is a very thin, underneath this is lipid. The second is as I told you, the attenuation of lipid behind it. This is the bad lipid which is going to rupture through. Then you have small microchannels which are seen here. These are the vasovasoria, which are usually the predisposing issues for rupture. You can sometimes, if you're carefully looking at, you can see macrophages in the coronaries. You can see spotty calciums at times, and at times you can even see the cholesterol crystal as highly reticle stuff, which is seen in the plaque. So all this stuff can create a very clear identification of a vulnerability of the plaque. And so we can see the lumen, we can see a TCFA, the thin cap fibroatherioma, we can see a large lipid core, which is necrotic. Then you have neoangiogenesis with microcirculation coming in. You have expansive remodeling. You can see the macrophages, which are can be seen. So OCT is very, very good because you can identify most of the stuff. When you have acute coronary syndrome, which presents to us with non-ST elevation, ST elevation, MI, you should know there are three ways. One, it could be a disrupted fibrous cap. That means, which I showed you, the TCFA gives way and you can give an underlying plaque with lipid. Two, it can be a calcific nodule, which has a calcium on the top, which protrudes, on which you have an attached thrombus, and that's an OCT, derived calcified nodule. And in some patients, you'll have the fibrous cap is intact, and you'll just have thrombus, which is attached to the plaque. This is called as an erosion on the OCT. And then there are the others, which could be just tight stenosis creating a problem, sometimes a SCAD, sometimes an intramural hematoma, sometimes a spasm, and sometimes a fissure. These can also present as ACS. So these are the important things. If you look at OCT, this is a typical plaque which has given way. There is a cavity where the lipid content has given into the lumen, and this is a typical thing which you see in an ACS of STEMI or non-STEMI of plaque rupture. This is a calcific nodule, a very, very refractile stuff which is poking into the coronaries and can form a thrombus on top of this and present as ACS. And you can have an erosion. Unlike here, where you have a TCFA which has given way, there is nothing here. There's just thrombus attached, and that is because of the endothelial dysfunction. Usually behind the endothelium, you will have some plaque, but the fibrous cap is intact here. This is called as erosion. In young myocardial infarctions, you see a lot of these patients coming with erosion. And finally, you can have other areas like SCAD, which is again I showed you in the previous picture. This is a SCAD, and you can see a small fissure. You can see a spasm. You can see the coronary when you are doing it before the nitroglycerin. It's this way, like this, the lesion on the OCT. You give nitroglycerin and everything opens up. So clearly you can see the proximal part is becoming bigger, and the title which you thought was a lesion opens up. So this is typical only spasm. There is some disease, but creating spasm. So these are the various lesion classifications. You should know that. So when you do an intravascular imaging of the patient, it's not, we should do it in a very serious way. When I mean serious, it has to be a proper run. You have to run it before, you have to run it during, and you have to run it after. And during, before, and after, there are various issues which you look at. You look at the assessment of the lesion. Is it significant or not? You look at the assessment of the lesion morphology. Is it fibrous? Is it fibrofatty? Is it high lipid containing? Is it calcium? Because your technology which you will use, for example, if it's a heavily calcific artery, you will use a rotoblator or a cutting balloon or a lithotripsy balloon or something else which you can remodify or modulate the plaque with. We also know that if it's a high lipid containing plaque, you have a risk of no reflow. You may also say that, okay, this is a very soft plaque. I don't even need to balloon dilate. I can put a stent. So you don't need a lesion preparation. You can use it for your sizing of the stent, which is very important. Most problems of stenting is when you either underestimate on an angiogram and put a stent which is undersized and don't deploy it properly. Post-procedure to see whether the stent has got optimized, has opened up well, and also for assessment of a failure of the stent, either for a subacute stent thrombosis or for the restenosis. Now, for non-left main coronary artery disease, some cutoff mean lesional areas are there. And this could be the minimal lesional areas in millimeters, various people have said, but it varies from, you can see from 2.4 to 4. So we cannot make out the minimal lesional area to make a decision in this, unfortunately, in a non-left main coronary artery disease. So MLAs vary from 1.9 to 4 among different studies, and the FFR to IVUS MLA is poor. So IVUS should not be used for diagnosing flow-limiting disease in non-left main coronary artery disease. But in left main, there is good data. And the most important data I would like you to remember is Hernandez data, which is 6 millimeters square, which is, if your lesional area is less than 6, then you need to intervene because it's usually corresponds to a good FFR or a significant FFR. And 2, it also corresponds to significant events. So it's important that you have, but you can see that the South Koreans brought it down to 4.8 because that was where the Koreans got an FFR of 0.8. But this is more validated for events, the 6 millimeters. So I normally say that if it's above 6, I don't intervene in the left main. If it's below 4.8, I definitely intervene. If it's between 4.8 and 6, I use an additional tool like a fractional flow reserve to check whether it is yes or no. So we can use these various ways to decide how to treat the patient. So I think in a left main, there is more good correlation. And I can use the mean lesional area to make out, mean luminal area to make out a decision of whether to fix it or not here. So this is the one study which looked at FFR guidance with FFR of less than 0.8 and an OCT guidance in patients where 75% stenosis. I don't know whether you can see it, but basically what it showed in this, if you use OCT guidance also, you can have a good endpoint of MACE as compared to FFR. But these are small studies. I would still, for all practical purpose for students, use an FFR to decide in non-left main vessels to decide whether to intervene or not. For the left main, you could use IVUS or you could use FFR. But post-procedure, to assess whether you did a good job or not, I think imaging is extremely important in the whole thing. Remember, sometimes lesions are very suspicious on angiogram. You don't know whether this is a guiding catheter related issue, whether there is some problem here or not, or whether it is a dye which you didn't inject properly. But you look, simply you took an IVUS and you can see a nice calcific nodule here, and this is a very significant lesion in the left main. You need to fix this. Here is another angiogram which looks odd in this part. You'll wonder whether this is disease or not, whether there's a plaque. And you can see clearly there's a thrombus. And this was a sort of a ruptured plaque in an ACS patient who presented with a thrombus in the coronaries. Here is a patient who has got a clear-cut plaque rupture. Again, an ACS patient. And it could always, for a minute, we thought it was a guiding catheter, a diagnostic catheter-induced dissection. But on looking at the IVUS, you could clearly make out this is not a catheter-induced dissection. This has got all the characteristics of a plaque rupture. There's a tin cap fibroadenoma, there is a cavity, and there is all suggestions of plaque rupture. Now, as I told you, attenuated plaques have a chance of embolic, going down and creating no reflow. And you can see if you protect those vessels with various ways, you can use sometimes spiders or protection devices, you can reduce the amount of nodal flow. So clearly, very high, big vessels with a lot of attenuated plaques should be protected so that you don't get nodal flow. So again, this is another European Heart Journal paper which shows simply that nodal flow is much higher if you have in a patient with a plaque rupture with a high amount of lipids. So if you have a lipid arc, which is 166 plus minus 60 as compared to 44, you get a very high nodal flow. So clearly, a degree of lipid arc in terms of 180 to 360 or more than 166 is important to suggest that these patients with a high degree of lipid arc will embolize and create. Now, calcium we can make out by scoring it. One, we know that calcium and thrombus are one of the poor predictors of outcomes during a procedure. Now, there are certain quantitative ways of getting a score on the calcium based on OCT. So, if this calcium angle is more than 180 degrees, you can point it as 2 points. If it's less than 180, it is 0 points. If it is thickness is less than 0.5 millimeters, it's 0 points. It's more than 0.5, it's 1 point. If the length of the calcium is more than 5, it's 1. And you have 0 to 4 points. And as the number of points increases, your events in the patient increases. We can also, for example, this is a very long calcified plaque. You can see all calcium right down here. There's a long distance of calcium. And you can see clearly these are long length calciums and they do not very well. Here's a calcium which is pretty much going almost up to 180 degrees. And you can see a dense calcium of more than 5 millimeters here. So 0.5 millimeters here. So these are calciums which don't do well. So these are the things which we should know when you're looking at calcium. So this is what you need to check when you're looking at them. You can also size and measure your lengths of stents, and we can do beautiful pictures with softwares too. We measure the distal, we measure the proximal, we measure the minimal luminal area in the distal, in the proximal. Then we can measure the lesion site, and you can get your reference diameter. So the mean distal luminal diameter up roundings up to nearest 0.25 millimeters. Means, for example, if you want to size your stent, you can either be very precise or you can measure your mean distal luminal area and use a 0.5 millimeter nearest test. For example, if it's a 2.75, you can use a 2.5 or a 3. I normally would go to a 3, upsize it. If your EMs are used, that means external elastic membrane to external elastic membrane, you downsize it to the less than 0.25 size. So EM to EM, I normally downsize a bit. Some people use the EM and EM go up to full size, but there is a risk of rupture. The Japanese don't do that. They downsize, while the Americans, they usually use the EM to EM and use a correct size of the EM to EM. Again, you can measure the distance of the length of the lesions by measuring from C to A and see where you want to place the lesion. Again, you have to remember, for making the landing zone, you have to have plaque burden less than 50% and absence of particularly rich lipid tissue. Because if you put a stent into a high lipid area and if there's 50% stenosis there, you will get restenosis. So you should be very careful when you do an OCT that you put your stent correctly and you tend to measure the lengths, maybe be a little generous so that we don't land up, putting up the stent into an area which is having lipid-rich plaque. Remember, we also have to have the stenting. Post-stenting, we have to look for problems. For example, the stents may be underexpanded. You can have dissections distally or proximally. This is the OCT dissection. You can have a geographical miss that you put the stent and miss the lesion. You can have a malapose stent, a stent which is floating inside the coronary. And you can have a prolapse when stuff protruding. You can see stuff protruding into the lumen when you have a stent placed inside. And finally, you can get something which is quite dangerous, intramural hematoma. If you don't pick it up, there's a small clot which is going through, and that can occlude the stent beyond the stent and go and occlude the vessel. So we have to be very, very careful with these problems. So what we do for stent expansion is quantified based on minimal stent cross-sectional area. A stent cross-sectional area, which is greater than 80% of the average of the proximal and distal reference luminal, or 90% of the distal CSA is a good minimal stent CSA. If the minimal stent area in the distal half is greater than 90% of the distal luminal area and the proximal half is greater than 90% of the proximal, is also a good way. So you can break the stent into two parts by the OCT software and use both. You can use the distal half and the proximal half and measure it. Or you can measure an absolute lumen area and make that your stent is expanded well. So there are various characteristics. I don't want to go through all these, but these are the Illumin 3 study which showed what to do and how to exactly measure the stent areas and how to make the ideal criteria of 90% distal and 90% proximal and do it well. Now remember, when you put a stent, you need to have a good cross-sectional area of the stent. And for drug-eluting stents, which we use today, approximately 5.5 in most proximal and mid vessels is a good lumen to achieve. If you achieve there, your restenosis rates will be less than 10%. In the bare metal stent era, you needed much more bigger areas. But now in the drug-eluting stent areas, about 5.5 is good enough in most proximal and mid areas. As I told you, we need to be very clear that stent expansion is a very important area of outcome. As you get out, with the cross-sectional area comes down and the main stent area comes down, you have more restenosis after stent expansion. So the minimum stent area should be in general greater than 80% of the average between the proximal and the distal reference lumen area. As I told you, that amongst all the areas, stent expansion is one of the biggest, predictor of bad outcomes in terms of restenosis. You can see in all these, minimum CSA less than 5 and residual stenosis are one of the biggest predictors of problems and outcomes in the future. The malposition means lack of the stent contact between the stent and the vessel wall. So the stent is sort of free floating in the vessel wall. Your various types of malposition, it could be acute or it could be late. Again, there are various classifications of each of these. Again, I'm not going to go into all these, but remember that residual acute stent malposition does not seem to predict big events. We try to get good outcomes, but late stent malposition, and if you look at outcomes in patients of OCTs, you can see clearly that most of the p-values are non-significant. So it's important to fix the problem clearly, but at the end of the day, a little bit of malposition, less than 300 microns, does not make a big difference in terms of outcomes in patients. Again, there are some studies in OCTs of late stent thrombosis and very late stent thrombosis seen in patients with malposition, but again, those are small, and I wouldn't worry too much in my opinion about malposition in these patients. Again, I'm not going to go through all the classifications of, but remember, undersizing is different from malposition. Undersizing means your stent is you took a smaller size than what is the vessel lumen. And under expanded means your stent is not come up to its full diameter. That means your proximal and distal is big, but the middle part looks crimped. These are bad things to happen. If you undersize or you underdeploy, patients get into trouble. That is not malposition. Malposition means your stent is fully deployed, but it has not made contact with the vessel wall. But if you have measured it correctly and put it correctly, late malposition diagnosis is more than 400 microns, extending for more than 1 millimeter. That is where we call it as late persistent malposition. Geographic miss means that you have missed the edge, and you put a stent and you have missed the edge. And these are the areas where restenosis can come. And because you've either ballooned that area, sometimes the balloon has hit that area and there's a plaque there, that's where we will get a restenosis coming in. Geographical miss, as you can see, is a predictor of outcomes, and you can get more restenosis in these patients. So as I told you before, if you have more than 50% plaque and your plaque is got high lipids, you will have restenosis if you put your stent in that area. So remember, these are two very, very important things, and residual plaque burden is a predictor of DESH restenosis. This is again a paper which was published in the European Heart Journal, again showing, as I told you again, about the lipid arc. And we have to very clearly understand that a high lipid content arc is a problem. Now, edge dissection can be various types. It can be like a flap. It can be punched out. It can be two lumens. It can come as a fissure. It can as only the intima. It can go through the media, and it can go up to the adventitia. So various types of dissection. But a bad dissection is usually related to vessel overstretching or disease at the stent edges. It also happens in a high plaque rupture lesion and with eccentric plaques. Again, many of the times you'll see minor dissections on OCT, and you don't need to fix. These are all minor things which happen. Many of the times, even in the left main with the guiding catheter, you see minor dissection. But if you get a big dissection, that's an event-producing lesion. So a dissection which involves more than 60 degrees of the vessel, circumference area of more than 3 millimeter in length, or a residual lumen comes down to less than 90%, that's a bad dissection. And in short, I normally use more than 60% of the vessel at 2 millimeter in longitudinal extension with involvement of media or deep layers. You should fix it with another stent. So this I'm showing you a picture. I'm not sure whether you can see it well, where you can see a patient who has had a stent deployed, and you can see clearly a stent being put in. You can see the stents being deployed here. This is the software that we use to pick the stent and to see whether the stent is well deployed. And what you can see next, what happens here, is you put another stent in the distal part and you close the dissection. Intramural hematoma means you put a stent here, and just beyond the stent there is a dissection into the media, and you can, or in below the intima, and you get a clot, and this is a hematoma. It looks like a dissection on the angiogram, but this can impinge on the vessel and close the vessel, and you may need to fix it because this has very poor outcomes. The incidence is 7%. It looks like a dissection or a new stenosis, and what happens is when you start to balloon it, it keeps pushing forward. There's a high incidence of non-QMI and sudden deaths in patients who have these things, and we should be very clear that you fix them easily. This is a patient who had an intramural hematoma, and you can see the intramural hematoma quite nicely here. Right now here, you can see it beautifully. And we have to fix another stent to do the whole thing. So you can have some very pretty pictures. I'm not going to go into these pictures for the brevity of time, but OCT can really reconstruct the vessels beautifully. You can see the stents, how nicely they are put, whether they are malopposed, whether they are deployed properly, and you can be very, very sure about how they have put the stents in place. Another patient with, again, intramural hematoma, which we have fixed. And here you can see the stents, they sort of crimp together and come together in these patients. And again, we should be very careful when you're putting these stents that you don't crimple them, especially in the proximal part, you can get them crimped. Here is a patient who's got a tissue prolapse. You put a stent, and inside the stent, you start seeing some stuff. This tissue is basically this, it's like a snowplowed stuff which comes through the stent and comes inside. And you can differentiate it with a thrombus, which is free floating, while this is sort of fixed and comes in. But if this goes in and occupies a lot of space, it can create problems in the long term. Again, there are various classifications of tissue prolapse, and I'm not again going to go through it, but the tissue prolapse is not a very benign thing if it's in a large amount. So if it's disrupted, it's irregular, it's large area, they are all predictors of poor outcome. The same way the thrombus, it's a large thrombus, irregular thrombus, and they can create problems in the patient. This is one of the studies which showed that if you have large tissue prolapse and thrombus, you can have poor outcomes. So I told you when you put a stent, what you have to look at is how is the the proximal part, the distal part, whether the stent is opposed to the wall. This is called as malopposition. You can see it's clearly malopose. It's not pushed up properly. This is under deployed stent here. You can see a dissection here, which is a large dissection, more than 60 degrees, and more than 2 millimeters you need to fix. If it's less than that, you may not fix. So you have to see the distal part, you have to see the proximal part, you have to see the stented part, you have to make the measurements, and then you have to make the mean stent area and know it by the reference lumen area of 80% or more. If you do this well, you can, if you get your areas to 5.5 and you get your areas more than 80% of average reference lumen area, your MACE events are pretty much in single digits. Now, for follow-up stent examination, you can see this was very useful in the BRS area. Right now, it's not so important. In the BRS, you could see the stent, whether it was covered, was it luminized, was endothelialized. All these issues can be very nicely measured in the post-stented area. You can also see after stent, a patient comes back. You can see now this is the stent and there's tissue inside. This is neointimal hyperplasia. And this can be a layered form or a heterogeneous form. These heterogeneous forms are not good and they can create problems of restenosis once you fix them again. You can have a stent put in, a restenosis sort of lumen which has happened, but more than that, you can have new atherosclerosis develop within the stent. You can have a TCFA inside the neointima. You can have calcification inside the neointima. You can have thrombus inside the neointima. And so these are important things for instant restenosis to have a look. You can have ruptured plaques inside a new atherosclerotic plaques. And you can have this late malopposition, which is sometimes maybe an allergic reaction, or maybe the artery was more ectatic and positively remodeled, and you can get the stent sort of free floating in the coronaries, and that can predict to thrombus and sometimes can create late stent thrombosis. Again, the causes of stent thrombosis today is basically either procedure related, which is under expansion, edge block burden or dissection, intimal hyperplasia with causing restenosis, new atherosclerosis, which can come up as new disease or ACS, late malopposition or aneurysm, which can cause thrombus. You can have the stent, which especially the long stents, which can fracture, especially the strong stents like the cipher can break. And you can have uncovered stent struts. That means the stent was not properly deployed, which can have stent thrombosis. So this all can happen in the era of drug-eluting stent. Then these come up either as stent thrombosis or restenosis. So in this 50 minutes, I've tried to take you through the whole area of imaging, and I'm happy to take questions from the audience. And if somebody can throw the questions to me, I can't see a chat box, but if somebody can throw the questions to me, I can take them from here.
Yeah. Nice talk by Dr. Mullasari. He could cover the whole topic of IVUS and OCT within 1 hour time, so precisely, with nice examples and very good take-home messages. And a couple of questions from my side. First, to start with, suppose you are doing an OCT, do you apply the same criteria for Leftman for MS to intervene? Of 6 millimeter, 4 millimeter, 4.8 millimeter? What is the criteria if you are doing an OCT?
So the first criteria, which was gotten by the Korean group for left main, was the 6, 7, 8, 9 criteria. These are no more good today. That was a criteria which was done with IVUS.
Yeah.
And today the numbers are much more different. It is 9, 10, 11, 12 minimum. So
the Excel data.
So the numbers have changed. So you need better lumens.
Yeah.
Now with OCT, there is no database of OCT showing in terms of outcomes like what the Koreans showed. So you can use OCT and say that the numbers, but in my opinion, OCTs are a bit smaller in sizing than the IVUSs. So you may get a 0.25 lesser, but there is no validated data with OCT for the left.
And the same thing applies for MSA of IVUS and OCT? you get 0.5 size or one size smaller.
0.5 size smaller. That's what you normally see with an OCT as compared to an IVUS.
What is your, because all attenuated plaque studies are based on IVUS data. The slow flow and Korean data are because of Japanese data and Korean data about slow flow is IVUS actually. What is the OCT criteria? Do you apply the same IVUS criteria to?
Unfortunately, the rigor of the OCT trials is not as much as the IVUS trials. The IVUS trials are many more than the OCT trials. Even for simple numbers, we are basically dependent on IVUS trials rather than OCT. OCT, we just sort of extrapolate based on the IVUS and say it's 0.5 millimeters up or down. But if you really know validated data, it's all with IVUS and not with OCT.
Yeah.
Even for
the same thing. There is an IVUS calcium scoring has come up recently in I mean TCT there 2019 they've discussed.
the
It's
calcium
almost a
score,
similar.
my personal feeling is it's much better on OCT because the calcium can be seen much nicer with an OCT.
Yeah.
The
Yeah.
typical that 4-point score which has been created is beautifully can be calibrated with an OCT. IVUS is more difficult to see those OCT, the exact length, the exact diameter, the exact thickness. Yes, there are various scores, but for me, an OCT is much far better for scoring for calcium, especially.
And
So there are some basic questions from the residents. Though you have covered those most of the things, so can you just tell the difference between the attenuation and echogenicity? These are the questions from some of the fellows.
So basically, echogenicity used for IVUS, attenuation you're basically using for OCT. What means that when the light goes through, the light becomes absorbed and the tissue becomes low intensity. That's what we call as attenuation. So it's a high attenuated plaque. It means it has absorbed all your light and the area of the lesion becomes low. Echogenicity we use for IVUS. It's a similar thing, but basically it's low echogenicity or high echogenicity. You can have both. And high echogenicity for the normal coronary is an adventitia. An adventitia has a high echogenicity, while the rest has low echogenicity in IVUS. But typically in a plaque, if you have a high intensity or high echogenic plaque, basically you have to know what you're meaning by it. So basically these plaques which have high attenuation or who are low echogenic plaques are basically the plaques with a lot of fat. These are the ones which create problems, plaque rupture, distal embolization and things like that.
Dr. Ajit,
yeah, go ahead, Ankush.
Dr. Ajit, few questions are coming from the students. Like they want to ask you, what is the role of imaging, especially OCT in acute coronary syndrome? Like they basically want to ask outcome and a predictor of outcome in erosion study and what we can see in future.
Okay, so in an ST elevation MI ACS, it is sometimes difficult to do an OCT because as such the artery is closed, there's blood clot, so you can't take a good picture. Patients are sick, you can't be doing imaging at that point of time. But you can, if you want to really, some studies have shown even in STEMI, it can be done that you do a mechanical suction, clear the vessel, make the flow better, then you can check with an OCT and see it. Most of the studies of OCT has been in non-ST elevation MI or in a post-thrombolized patient who comes in where you are more stable, you can use the OCT. What you really see is the type of plaque rupture, whether it's a erosion, it's a plaque rupture, is it a plaque calcified nodule, it's a SCAD or whatever else. In general, in the West, in non-ST elevation MI, you see a lot of plaque erosions, while in India, with extremely young MI, you get more plaque erosions in Indian population.
So what is the implication of that? So we
Well,
are
the
seeing...
implication is very important, and that's one part of the study which Arun was talking about. In the erosion one study, it was shown that it was a Chinese study of one center. It was shown that if you had plaque erosion and your area was reasonable in the lumen, you did not need to put a stent, and you need to only treat the patient with medical treatment, which is dual antiplatelet therapy and 2B3 receptor blocker. And the patients did better than the patients whom you put stents in for. So if there is no plaque and there's only clot with a mild erosion, there is no absolute requirement for the stent. And this is what hypothesis we're going to check in the erosion 2 study in India.
And what about if you have got a acute vessel occlusion like ST elevation myocardial infarction. You did a suction and you just saw a bit of plaque that led to thrombus formation, but actually plaque burden is not too much. So what do you suggest about that?
Well, in a plaque rupture, it has not been studied very well. The deferred study, which showed in plaque erosion that you deferred it and treated medically, did not show a good outcome. But in plaque erosion, it has been shown clearly in the erosion study. But in a deferred strategy of a plaque rupture with less plaque, you may be technically right that you may get away without a stent, but it has unfortunately not been studied and proven in study. The deferred study was negative.
So, what is your opinion? So you have got acute occlusion of vessel. You did thrombosuction. You did the OCT. There is a little bit of plaque rupture is there. There's not too much of plaque burden. You don't have a thin cap fibroathelioma. So, what is your practice? What do you usually do?
Well, we have a lot of patients in this group, and in fact, me and Vijay have done some work on this, and we definitely leave the patient alone. We treat the patient with medicines. We treat them on dual antiplatelet. If it's eroded plaque and there is a lot of clot, which is red thrombus, we may add warfarin or a NOAC on the patient because it seems to clean up the artery much better than dual antiplatelet.
So another question that is coming up is, what is the effect of PCI optimization by OCT in long-term outcome?
So unfortunately, we never had a good data, and we are now going to have the Luminal 4, which is the randomized study, where you're going to use OCT compared to no OCT and look at outcomes by optimizing stent implantation. So this is supposed to start in November, December. We are one of the sites worldwide. And that may show that by optimizing OCT, you get good outcomes.
The last question that is coming up, and 2-3 students are asking about how to differentiate between malapposition and underexpansion.
That's a very
So just a common sense, underexpanded stent is that you put a stent, the distal part of the stent is kissing nicely against the wall and is opened up nicely. The proximal part is also nicely kissing up on the wall and is nicely opened up. Well, the middle part, where there's the plaque, is not expanded, and the plaque is restricting that stent. So it's an underexpanded stent. And estimated stent is a different story, where you undersize or underestimated stent is basically you size a stent which is for a 3 millimeter artery, you put a 2.5 millimeter. That stent is undersized, so it will float in the coronary, a 3 millimeter vessel and a 2.5. So you have not measured it correctly. You have not measured lumen properly, distal, proximal, or EM to EM, and put a stent wrongly. While a malapose stent is you have done all that properly, you have put your stent properly, but some parts in some areas, the stent is not touching the wall. Those are malapose. As long as they are less than 300, you can just leave them alone. There's no problem. If it's more than 400 and free floating, we can have bad outcomes. But again, malapposition, usually small malappositions don't create problems.
Perfect.
Sir, one interesting question. Role of intravascular imaging in the choice of devices used for calcium debulking.
Okay, so if you have a calcium, remember it is one of the predictors of bad outcomes acutely and in the long term. So for calcific lesions, my strategy is always image. When I see calcium on the coronary, on the angiogram, and I want to do a PCI, I always use an imaging. You can use an IRIS or you can use an OCT. It's up to you what you want to use. But why I use it? One, see whether the calcium is in the intima, in the media, or it's in the adventitial. If it's adventitial calcium, we don't have to worry that much because the stent will still expand. If it is intimal calcification, then we have to know the extent, the scoring which I told you, whether it is thin, whether it's thick, whether it's long, whether it's 180 degrees, whether it's 360 degrees. If there is a large calcium burden and the lumen is small and it's totally sort of large degree of calcium and you have to debulk it, the best way to use is a debulking device like a rotablation. If your lumen is large, you're 180 degrees, then you can use a lithotripsy balloon, You can use sometimes a cutting balloon or an angiosculpt because those balloons will go through and cut. But usually the sculpts and the cutting balloons don't cut the calcium. They cut the normal area and expand that area, not the calcific area. But to really debulk, you need to have either a rhodoblator, lithotripsy balloon, or you can use the high pressure balloons also.
Perfect. I believe another advantage of imaging is underexpanded stents in calcified lesion. As sir rightly said that if you are suspecting calcium, you should always go for imaging. You should know how much calcium is there. If you don't see the calcium, you will end up in having underexpanded stent. And then also imaging can be helpful. You can see the amount of calcium and you can appropriately choose your device to treat that underexpanded stent.
So the most common complication that you see in a meeting is that I saw a lesion, I ballooned it with a small size balloon, and then I put a stent, and the stent is not coming up. And this is the biggest disaster you can have because your calcium is now restricting the stent. It's an underdeployed stent, and this stent will create either stent thrombosis immediately or restenosis. This can be completely avoided if you do an imaging and see the calcium where you debulk the calcium, open up the vessel by clearing up the calcium, and then putting an appropriate stent.
So,
There is one question, sir. Does OCT overestimate the lesion severity?
No, it is almost exactly like an angiogram. I would say that IVUS overestimates it slightly, but an angiogram and OCT have absolutely equal sort of measurements.
yeah. So if there is no more questions, can you just give a message to our beginners and senior resident and DNBs, DMs, how they can incorporate imaging into their training and they do much more program, because you are a founder member of IPCI, so we can have some programs or something for these residents maybe.
See, for residents, I want to tell you that two things. One is that today your examinations have gone a different way. The pandemic has changed the exams into a 25 spotted exams. It's no more about only clinical exams, number one. So you're going to see ECGs, you're going to see echoes, you're going to see X-rays, you're going to see clinical cases, you will see images, you will see OCT pictures, you will see oximetries, you'll see for your exam. That is one part. To clear your exam, you need to know all these things when you go for the exam. The second is post-exam when you're doing interventional cardiology. Now, to do interventional cardiology today without imaging inside the coronary is simply like doing a transcatheter valve therapy without doing a CT scan. It's guessing a lot of things, and putting the wrong size valve into patients and running into complications. So I feel that if you're running a cath lab and you don't have imaging tools with you, you're going to be not a good interventional cardiologist, and you're going to get into trouble into the cath lab for some point of time. So at least one or two of these tools and fractional flow reserves is mandatory when you start your cath labs, along with your angiogram, obviously your cath lab. Second thing is to be systematic in reading this. This is just like another tool, like echocardiogram. How you learn echo. You should know IVUS and you should know OCT and train with that. We started IPCI because of this need, which we found that people was very superficial in their learning of these imaging tools, and they felt that they knew everything based on the angiogram, where we don't clearly, you can't make decisions based on angiograms. Angiogram can underestimate a lot of things. So IPCI's aim was to teach, and we have now small groups all over the country which can train 8 to 10 doctors together with basics and advanced techniques. And the IPCI big meeting was started by many of us for this reason only, and it hopes to train people in interventional cardiology in the right way. I think without knowing imaging today, your restenosis you cannot bring down below 10%, and your stent thrombosis you cannot get to less than 0.5% without imaging. If you do this correctly, even in the difficult lesions, you can bring your restenosis to less than 10% and your stent thrombosis to less than 0.5%.
So, after the words of wisdom by Dr. Ajit, I think, sir, we are very fortunate to have listened to you, and it will help all the faculty members as well as other resident fellows who are in their training to not only hone their skills for the exams, but also for their life after that. Thank you so much, sir. And it's an honor to have you here as a part of Delhi CSI.
Thank you, Girish. Thank you for the opportunity. Thank you, Arun. Thank you, Ankush, for taking me, and thanks, Intas, for giving me this opportunity. I hope the residents have learned, and I think you should continue to learn. I would suggest a couple of papers which me and Vijay have written for the basics of OCT and IVUS in Indian Heart Journal. I think it was about
there's a review article supplement.
In the interventional part of Indian Heart Journal. It's pretty exhaustive and could be useful for you for the initial part of the learning. Thank you very much.
Thank you, Ankush, and thank you, Varun, for having graced the occasion for this lecture. And for all the fellows, the next week we have a masterclass by Professor Anita Saxena on oximetry with case examples, how to interpret oximetry data with case examples. That will be next Friday. And I would also like to take this opportunity to thank Mudit Prashant and others from Intas Pharmaceuticals who have graciously accepted our invitation to be partners in this endeavor of ours from the Delhi CSI. Thank you one and all. And let us meet next week and next Friday for a masterclass by Professor Anita Saxena. Thank you.
Yeah, thank you, Mohit and Girish, for a nice, wonderful job you are doing for residents.
Thank you. Thank you so much.
Okay, you are doing a wonderful.
Mohit and Dr. Girish. And, thank you very much.
Thank
you. Okay. Bye.
Bye.
Bye, sir. Good night.
Bye. Good day.